Good afternoon. It is great to see you as always on a Tuesday evening at 4 p.m. in the Mountain Time. My name is Dr. Randy Fink, and you are live with Fertility with Fink and Friends. I am Fink, you are friends. Live from Colorado Springs, CNY Fertility. I am also the medical director at the CNY Fertility Center at the Miami Center of Excellence in Miami, Florida. And it is so nice to be here. It is my favorite time of the week to spend this time with you. And it's good to see everybody stepping in. Hello, Miss Amber Vincent. Congratulations on your wonderful genetic testing. And it looks like Fairy Tale 404. You are number one on this Instagram side, and over here on this one here. Hey, Deanna, nice to see you. Let's see who was first. Yeah, Deanna, you were number one, my friend. So it's good to see Grace and gosh, all my friends. It's me, Callie. Who's over on the Facebook side, my friend? Tamisha, hello from New York, and hello from Colorado Springs, where it is a beautiful 78 degrees here this afternoon. I think some of the rest of the nation is still really suffering with the heat and the fires, and now, of course, to all of our friends in Florida on the Gulf Coast who are going to be dealing with the imminent arrival of a hurricane. And I have to tell you, having moved here to Colorado from South Florida, it sure is a big change to not have to look at the tropics at all and wonder where the next hurricane is coming from. But that reminds me of an interesting little story that I will share with you. And that has to do with my beautiful little daughter, who is 11 years old. Her name is Ruby. So one of the cool things about being here. So when I lived in South Florida, we had crocodiles in the backyard. I kind of lived I lived in the Florida Keys, which is a kind of mangrove swamp, very tropical. So we had, it's the only place where there's saltwater crocodiles in the country, which is an interesting thing to have in your backyard, but all kinds of great birds, and there's a key deer down there. There are these little deer that are about the size of dogs, so they're really cute and they're really interesting when you see them. But here in Colorado, we've got bears. Very frequently bobcats. Deer are in the yard pretty much every single day. But one of the coolest things that we have is there in this season, there is hummingbirds. We are just loaded with hummingbirds. You put up a little hummingbird feeder, and they are absolutely the coolest little birds to flit around, and they play with each other, and they'll come and they'll like buzz you kind of right here and look at you in sort of a funny way, and they're really awesome. The problem is, you see, and that's right. And thank you for pointing that out, Amber, and a fox. In fact, if you look at my Instagram, we had a fox who came in. We left a plate of food out for her, and she delightfully peed on it for us, right for the cameras. And I did put that on one of my Instagram videos. If you haven't seen it, it's actually really funny. So take a look there. Nevertheless, we have cats. I've got a beautiful dog and a bunch of cats. And one of the cats, whose name is Timmy, is fascinated by these little hummingbirds, and of course does what cats do. He wants to try to eat them. He tries to jump after them, and he makes some crazy, amazing jumps. Sometimes you see him do these incredible flips trying to get one of them out of the air. Well, sadly, occasionally he does actually get one. We try not to leave him outside unattended so that he is able to get them, but he goes out on the balcony, and sometimes we just he's too fast for us, and he'll go after a bird. And most of the time he's kind of a little clumsy, and he doesn't do anything. But yesterday he managed to catch a little hummingbird, and immediately we were there. Timmy, no! He tries to run in the house with it in his mouth, and eventually what happens is he goes in goes in the house and he opens his mouth, and then the bird, flies out and then is stuck in our house for a while. So that's suboptimal as well. But this one, we managed to get it away from him, but it injured this poor little bird, not dramatically. So it stunned the little bird. But so we decided that we would open, by we, I mean, my daughter decided that we would open a little hummingbird hospital. So now I am also in the hummingbird rehabilitation business. And this little birdie is very, very sweet. And, you can hold the little bird and pet the little bird. And of course, we feed them nectar and put a little heating element out so that I believe this was a female, that she would stay, warm during the night. And I just thought it seemed like that there was some kind of message in there someplace. And it's that, nature is such a beautiful thing, and it really is. Nature is beautiful when it works the way it's supposed to. And I suppose you could say it works the way it's supposed to when a cat goes and chases a bird. That's what cats do. You can't be angry with them for being a cat. But then, when things don't work the way they're supposed to, it's still really pretty, and it's nice to be able to hold it in your hand and to know that there are people around who really want to try to help to heal those wounds, and for that little bird to be able to fly away. And that's the analogy I kind of feel like today, that it's so nice when things work the way they're supposed to. They don't always, but it's so good to have such a supportive group of people here around who can really try to make it all right. Not just this great group of people at CNY, but particularly you guys for being here and supporting one another. So thank you for that, and all the best thoughts to the little hummingbird who's at home kind of hopping around a box. We're waiting for the wing to heal so that she can just fly away. So what else we got going on here? Hi from Indy to Rachel. Hello, Natural Tay from Florida. To Classy, good to see you. Mrs. Ty Marion, nice to see you there. Lena Sweet, things to help with ovarian reserve. So that is a very good question. There is a book on that subject, and it's called It Starts with the Egg. Starting with the egg, there is a great list of supplements that come from that, which I'm happy to share to you. Just instant message me here at Randy Fink MD, and I am happy to send you that list. It really does show that there are some things, there probably is a window that we can use to improve egg quality and potentially ovarian reserve. I have seen repeatedly people taking the right kind of supplements who result in actually their AMH level going up. But more importantly, it's not just about quantity, it's about quality of egg. And that I really feel like we can do something with from a supplement standpoint. Also from a medication standpoint, metformin is a medication that we use specifically for egg quality. Metformin is a drug that's used to treat folks who have diabetes, but we can use it. Let's see, we use it in people with polycystic ovarian syndrome because it helps them to be able to ovulate. And specifically in the IVF world, metformin helps with egg quality. Omnitrope is a human growth hormone. That's another thing that we use in women. Interestingly, I was having a conversation with a fertility urologist today. We don't use it in men for DNA issues with sperm, oddly enough. There are some more interesting solutions that may help with DNA fragmentation and sperm quality, and that has to do with frequency of ejaculation. The more you ejaculate, the better sperm comes out. Who'd have known? So let's see what else we got going on here. I saw a question from Haley Gunter. Hello, Haley. Is transferring more than one embryo at a time discouraged if someone has had multiple losses. So there is a guideline that we usually follow for how many embryos we recommend that you transfer. That is, the guideline comes from the American Society for Reproductive Medicine, the ASRM. And in general, the goal is we want to have one healthy baby at a time. We really are not enthusiastic about giving people twins or certainly higher order multiples, because most of the bad things that are associated with IVF and fertility outcomes are related to having multiple pregnancies, having twins, triplets, and so forth, because it virtually guarantees that you will have some kind of preterm delivery. It increases the risk for prolonged NICU stay, potentially severe preterm delivery, cerebral palsy, birth injury, certainly C-section, and so on. So we're never enthusiastic about giving people more than one baby. But yes, there is a scenario, Haley, where if you have had multiple failed transfers, that we may say, all right, in this situation, you're probably going to be better off if we put in more than one embryo. Usually when that happens, it's not because we are hoping that both embryos will stick, but rather we are trying to increase the probability of having one of those embryos stick. So now when you say someone who has had multiple losses, if you're talking about having had multiple miscarriages, then putting in more than one embryo at a time is probably not the best idea. Why is that? Because putting in more than one embryo and having multiples increases the risk of miscarriage. What we want is for at least one of those embryos to stick, thus resulting in a positive pregnancy test. So those two things are not the same. So it depends on kind of what you mean by multiple losses, but certainly something that we're always happy to talk with you about there. Nice to see you, Haley, and thanks for being here. Good afternoon to everybody. Happy Tuesday. Fertility with Fink and Friends is the place where you want to be. Well, it's a good thing you want to be, because you are. Let's go to this side. Hey, Nikki Jones Fit. Welcome back home. Nikki was just visiting with us in Colorado, and it was sure great to meet you, you guys face to face, because it's so fun to meet people, over social media and on Instagram, and to have contact with people. But there is nothing in the world like seeing someone face to face and really being able to give somebody a hug, shake a hand, and really know that there is a human being on the other side of that cool Instagram handle. Shanna says, if you do a modified FET, how early will you know the date of the transfer? Trying to plan for next month. Oh, look here, Buddha B is with us. Hi, Buddha B. It's nice to see you. I haven't seen you around for a while. And Nikki's saying, oh, it's nice meeting you in person. You're just saying that because I said it. I know the way you work. So to answer your question, Shanna, when you do a modified natural, or even a natural cycle FET, what's happening there is that we're letting your body contribute some of your own hormones to the procedure, as opposed to using entirely synthetic hormones or hormones that we are putting into your body. We're letting your own hormones do it. One of the common misconceptions about that is that we are just leaving it to nature, saying, okay, well, here's your embryo. Let us know, if you get a pregnancy test afterwards. It is nothing like that. We still monitor you very, very closely. The issue is that we simply want to let your own hormones contribute to the equation. Well, so if you develop an egg, you develop a follicle in the ovary. As that follicle grows, this is what gives you your estrogen that lets your lining get thick. That thickens up the lining like it does in every other cycle that you have, even when you're not trying to get pregnant. Because if you have a period, that means that lining is building up. It's doing something. It's waiting for a pregnancy to land in there. So we're going to take advantage of that. Then when we see that the follicle in the ovary has grown to a mature size, we can trigger the release of that egg. We can trigger your ovulation. And when we trigger the ovulation, if you have a blastocyst then your transfer is going to be taking place 1 week later. All right. So can you tell from the beginning of the cycle when that travel is going to need to be? No, because we don't know exactly when your egg is going to be mature, or when your follicle is going to be mature. But we will know 7 days ahead of time from the time of trigger when you're going to need to be here. So hopefully that helps there, Shanna. Let's go over to the Facebook side, which I missed a couple of questions last week. And in fact, when I missed them, I saw after we signed off, somebody said, "You didn't answer my question." I'm like, "Oh, I'm sorry." I swear. Just so you know what's happening here is I've got a Facebook and a YouTube feed here. We've got a couple of different Instagram feeds here. So I'm trying my best to see what everybody's writing and not have to just keep staring at the screen. Plus, I got smudges all over my glasses and my vision ain't what it used to be. I'm an old man. So forgive me if I don't get to your questions, but we will certainly try. Tamisha asks, I'm 38 and my FSH is 9.4. My AMH is 5.48. What protocol would you suggest? So, Tamisha, you bring up an interesting point to illustrate here. So you're 38 years young, which is fabulous. Your AMH is 5.48. That's a very good number as far as ovarian reserve. And that's what the AMH measures, the anti-Mullerian hormone. When that number gets above about a 5, we start recognizing that your ovaries are going to respond really well to stimulation. In fact, you are at risk for having polycystic ovaries and for potentially becoming hyperstimulated. So normally when we pick a dosage for you, a dosage of what medication we're going to use for IVF, we pick that number based on your age. So first thing we think about is age. And so standard way to think about that, Tamisha, at 38 would be that I might use 300 units of FSH drug. So that's Gonal-F or Follistim. We can use Menopur or we can use HCG-LH. At CNY, we typically start with HCG-LH because it is significantly less expensive than the other choices. And so that's what you'll find that is in our in the bundles, in the medication bundles that you can get. It's HCG-LH. So that would be 330 units of HCG. That would be an age-appropriate dose. Now, when you start thinking about the AMH being a little higher, if I use the age-appropriate dose, that may result in hyperstimulation for you. So some people would suggest that we drop the dose. Then instead of 300 of Follistim and 30 of HCG, that we would use 200 of Follistim and 20 of HCG. And that's also what we call our mini dose IVF. And that's 10 of letrozole, 200 of FSH, and 20 of HCG. And that's probably the conversation that we would have when we were thinking about what was going to be the best choice for you. Kinsley is asking, what is better for those with PCOS, fresh or frozen transfer? The answer to that, my friend, is probably a frozen transfer. And because, like I said, when we were talking about Tamisha there, your ovaries really get into egg making mode. They are so good at making eggs when you have PCOS that you tend to respond really, really well to medications. And when that happens, a lot of times, well, the more eggs we have, the higher the estrogen level will be. And that estrogen level is one of the things that controls how hospitable your body is going to be to an embryo implanting. Now, a lot of times at CNY, we use the letrozole medication, which will artificially lower the estradiol or the estrogen level. So it's not always a good marker. But if you've made yourself a lot of eggs and you responded really well, your body was so into egg making mode that being in pregnancy mode may not be consistent. It just may not be the best idea. A lot of times we can tell just from kind of looking at the ovaries and from doing the retrieval. Sometimes it's going to be based on the hormone levels. But if you ask me to sort of say up front for somebody with PCOS, is it going to be better with a fresh versus a frozen transfer? I would tell you it's probably going to be with a frozen transfer, because you are going to be an egg maker. And being an egg maker may keep you from being as good at being pregnant until that lining sloughs off, until you get your period. And the next thing you know, you're ready to have a frozen embryo transfer. So hopefully that is helpful there, Ms. Kinsley. Let's see what we got else. What else is going on over here on my Instagram side? What is the process to sync up cycles in order to do a fresh transfer when using a known donor? That comes from none other than world famous Amber Vince. Amber, good question. So this happens not only when someone is using a gestational carrier, but also in the case of, let's say, reciprocal IVF, when a married female couple, one of them is going to provide the egg to make the embryo with donor sperm, and then we're going to place that embryo back inside the other partner. Well, so what we have to do is we have to sync up the cycles so that the timing works out. What's the easiest way to sync up a cycle? It's birth control pills. So birth control is what we'll do to kind of make that magic happen. And usually that makes it a relatively straightforward process. It's not always perfect. So you still have to have a little bit of some flexibility with it to know that it's probably going to work, but there's a slight chance that it might not. But birth control is really the way we do that. Good afternoon to Ryan from Anesthesia, one of our wonderful CRNAs who is joining on the Instagram side. Ryan has been out for a few days, and we have missed him very much, but not so much that we would welcome him back. So thanks for your service. It will no longer be required. Okay, what else here? I hope you're laughing at that. Ryan has a wonderful speaker, like a Bluetooth speaker. In addition to being a great anesthetist, Ryan is a fantastic DJ, and will happy to put you to sleep, and is happy to put you to sleep and to keep you to sleep to whatever sort of tunes make you the happiest, so that when you wake up, you know it's going to be in a happy place. Unfortunately, Ryan, while you were gone, we broke your speaker, and you know, it was good while it lasted. So thanks for that. Erica Walden, good afternoon, my friend. Do you recommend doing a hysteroscopy during an egg retrieval with a fresh transfer to follow? My gynecologist tried to do a sonohystogram twice, but couldn't get the catheter in. My HSG was clear. So the HSG is really a good test for evaluating the shape of the uterus and that your fallopian tubes are open. It is not such a good test for evaluating what's on the inside of the uterine cavity. Really, a hysteroscopy or a saline sonogram is the better test for that, as you allude. However, if you're planning to do a fresh transfer, we do not want to do a hysteroscopy at the time of retrieval, because we don't want anything touching that uterine lining when there's going to be an embryo going inside. So I would recommend, if you'd like to do the hysteroscopy while you're under anesthesia anyway, which to me sounds like a fantastic idea, because who wants to feel that, you know? Listen, I've been a gynecologist for a very long time, and I think if I needed to have a pap smear, I might want general anesthesia for it. Men are babies, there's no question about that, but still, I don't want to necessarily feel a hysteroscopy if I can avoid it. So if you're going to be asleep anyway for an egg retrieval, then I think it's a good idea to go ahead and do a hysteroscopy. Although all of our locations will not do that. We do that here in Colorado. They will do it in Syracuse. I'm not sure about Buffalo, but I know that the doctors in Albany will not do a hysteroscopy at the time of an egg retrieval. But Erica, you don't want to do that if you're planning to do a fresh transfer. And that is the reason why. Let's see. Deanna's asking, is a fresh embryo transfer possible for endometriosis patients? If so, what should be done prior? An HCG wash. So I think an HCG wash is always a good thing to do. HCG, of course, is the pregnancy hormone. And with an HCG wash, we take a little bit of that hormone and we place it inside the uterine cavity, a teaspoon or so, a little bit of that fluid inside the uterine cavity, which touches the lining, and it turns the volume knob up on some of the little proteins and things that are associated with being receptive to that embryo coming in. So does that make sense? If you, I just said when we were talking about hysteroscopy, we don't want anything touching that lining if you're doing a fresh transfer, except if you're doing an HCG wash or a Neupogen wash or a PRP wash, which are the other things that we can do under differing circumstances. So HCG wash, I think, is a great thing to do really for everybody. Nothing specifically there, Deanna, as far as endometriosis goes. Yes, if you have endometriosis, you can do a fresh transfer. There are some people with endometriosis who have no problem, not a problem in the world, getting pregnant. And there are some people who have recurrent implantation failure, and then we figure out they have endometriosis and we conclude, well, maybe that's why. And then if we treat them for that endometriosis, they are then able to successfully implant a pregnancy. So it just kind of depends on where you fall in there, Deanna, because if you've been unsuccessful several times before, and then we figure out that endometriosis was involved, what we know is that suppressing that endometriosis for 60 days makes a tremendous difference in the success of your embryo transfer. But there is no reason at face value that you can't do an embryo transfer. And in fact, at CNY, the fresh transfer is included in the price. So if possible, yeah, do a fresh transfer. Let's see what else we have going over here on the Facebook and YouTube side. Or Facebook, what do we got? Facebook, YouTube, and LinkedIn side. Rachel is asking, how often should you check your FSH and AMH for updated numbers? Well, if we're doing fertility treatment, usually we will check that FSH at the start of every cycle, because it just kind of helps us to know that you are in fact at your baseline, that you're early on in the cycle, because earliest on in the cycle, that FSH should really be at its lowest. As far as the AMH goes, as long as we, I like to know what it is kind of once a year, especially if we're doing, ongoing treatment, because it may help us to tailor that treatment to you. But much more frequently than that, the AMH doesn't really change things too much. Let's see. We have Laura Ramirez here from Ohio. Good afternoon. Onyi is here from Houston. Boy, this is quite a day. Let's see. Emily is with us, who had a retrieval the other day, and she said she got to fall asleep to Garth Brooks. And so I don't know if that was your request, or if we just assigned Garth to you. I can't remember, but that's great. Angela's here from North Dakota. And oh gosh, we're going to see you on Thursday. How excellent. Very exciting, my friend. Okay, Megan is asking about my AMH increased from 0.4 to 1.13 in less than a month with the supplements and fertility acupuncture. How did it jump so much? Wow. The doctor told me it wouldn't change, and if it did, it would be super minuscule. That's fantastic. Megan, that's awesome. We actually ought to probably write a book about you. I think that's great. I have seen very similar things happen with other people. I think the supplements do make a huge difference in terms of their antioxidant quality. Antioxidants are used to treat something that's called oxidative stress, which is where basically what we know as free radicals, or a byproduct of our metabolism, ultimately starts to damage our cells. So it could be that, and acupuncture is probably, who really knows exactly what the mechanism is there, but it probably has to do with function of blood flow going to the ovaries. And so if you got better blood flow to your ovaries, it would probably go to show that your ovarian reserve had improved. So that is really fantastic. And so I hope that that turns out to be very much in your favor ongoing. Very happy to hear that. Laura's asking after 3 times frozen embryo transfer and 3 losses, do we recommend an HCG wash? Yes, not only an HCG wash, but I would also recommend that you do a PRP wash. We've talked about PRP before on this show. If you're not familiar, PRP is platelet-rich plasma. What is PRP? PRP as a wash in the uterine lining is very useful and evidence-based in treating folks who have both recurrent implantation failure and recurrent pregnancy loss. So what it is where we take a tube of your blood and we separate out the portion of your blood that contains your what we call your tissue factors, your growth factors, your healing factors. It's the most healing salve your body can make, is the way I like to describe it. And we're basically able to make it in a little tube of blood. So we take a bunch of tubes of blood and separate out that component, and it ultimately ends up in this sort of little orange looking stuff, which we can then place inside the uterine cavity. It is extremely healing and extremely good for that uterine lining. Also very good for folks who have a difficult time growing their uterine lining, or people who have had scar tissue on the inside of the uterus, which is known as Asherman syndrome. PRP is very useful in that regard. You may also know PRP because it's used to treat joints, sick joints, knees and elbows and shoulders. It can be used, it's used very commonly in aesthetic medicine on the face. It can help you also to regrow hair when placed into the scalp. And it seems like every time I say that, then I kind of always end up turning my head to kind of want to see where I could use a little PRP up there. But sorry, that's just me. Does CNY do that PRP? The answer is yes. It's prepared in our lab using some special tubes. Again, simply we also do PRP to be placed in the ovaries, which is something that's called ovarian rejuvenation, which is considered experimental, but it does seem to make a difference in a lot of people with diminished ovarian reserve or with egg quality issues. So I think the world of PRP. Hello to Jenna and Pretty Face 103. Hey, nurse therapist. I like that name. I'm even going to send you a wave. There we go. So let's see if we have some other, lots of friendly faces here and lots of names that I recognize. It's great to see everybody on the CNY Instagram side there. Fairytale 404. I wonder if you're from Atlanta. When using an egg donor with fresh eggs, do you all freeze and transfer day 3 embryos or day 5s? So it really ultimately depends, Ms. Fairytale. May I call you Ms. Fairytale? It all depends really on kind of how many embryos you end up making. So our usual protocol is that if you have 5 or more embryos, we recommend that you grow them out to the blastocyst stage. If you have 4 or fewer, we recommend that you do what you're going to do with them on day 3. Now, what's the rationale for that? Well, the other thing is that if you're planning to do PGT testing, pre-implantation genetic testing, if you're going to test the embryos for chromosomes or gender, you have to grow them out to the blastocyst stage. So that has to be day 5, day 6, or day 7 embryo. But otherwise, what's the rationale? The rationale is if you have a lot of embryos, then growing them to blast just sort of lets nature help you to select which embryos have the greatest probability of being able to get you pregnant. So they're not all going to make it to that blastocyst stage. So nature is going to help select, the ones in theory that may not grow, that may stop growing, may stall out is the term that we use. That may happen because something is wrong with the embryo. Whereas if you grow it to blast, it's lasted a little bit longer. right? A day three embryo is an embryo that is still trying to divide. It's trying to figure itself out. It's a bunch of cells that are just, trying to grow, trying to figure out how to make themselves keep growing. That's what's called a cleavage stage embryo, because it's cleaving, meaning to say it's dividing. A blastocyst is a little functioning machine. It's a little piece of machinery. It's a little factory that's already working. It already has all these metabolic processes going on. It's a whole bunch of cells. It has lasted to a point where we know that having a blastocyst, the blastocyst has a higher probability of being able to get you pregnant. Why is that? Because it lasted a little bit longer. However, if we are limited in the number of embryos, and I will say as a caveat there are many fertility practices that will not transfer anything other than a day 5, or other than a blastocyst, which is typically day 5. Why is that? Because they're very concerned about their success rates, and they only want to show that they want to artificially elevate the kind of numbers that they have, in my opinion. There's nothing wrong with a day 3 embryo. If we're limited in the number of embryos, I would much rather see that embryo going inside of you on day 3 instead of potentially not growing in the laboratory. Because you may have the magic sauce that we don't have in the lab. And I always say the worst, sickest the worst, sickest uterus is still way better than anything we have than the best laboratory there is. I would much rather see a uterus. Oh my goodness. I would much rather see an embryo going inside your uterus than an embryo potentially dying in the laboratory. So if we're limited in the number, we're always going to tell you, put that embryo inside of you where it's going to have a chance, because it may grow with its mother inside of you, whereas it might not grow inside the laboratory. If you've got a lot of embryos, sure, let nature help you to select. You're going to end up with fewer embryos, but that's okay, because it's also going to mean fewer embryo transfers to have to do. All right, what else we got here? KP Stew says it starts with the egg is phenomenal, and I love seeing a doctor recommending it. Well, in fact, you know what? I always keep it close by. Yeah, it really is a wonderful book, and it's fairly easy to read. Half that book is bibliography. It's the studies. So I always tell people, when we talk on the phone with consults, that it's the Bible of evidence-based practice for supplements. So I think it's a great thing. Oh, let's see here. What do we got going on? Brianna says, if I have an AMH of 0.3, am I able to know how much longer I have before I'm at 0? No, unfortunately, there is not necessarily a time correlation between how that AMH starts to go down. Now, there is a graph that you can Google on AMH related to age, but that is based on average AMH for age. There are some people who are very young, who for one reason or another, usually thought to be to some autoimmune situation or to some sort of blood flow or some kind of toxin problem, resulted in having a lower than average AMH, which is what we call diminished ovarian reserve. And when that happens, it happens like a strike of lightning. There's it's unpredictable in most cases, and we rarely can actually point a finger as to why that happened. So really, the diminishing of the anti-Mullerian hormone related to age is shown in the graphs, only showing basically what is the average AMH for age. But since different people have different levels based upon different things happening to their body, it's very hard to predict what that means in terms of, we can't look at it and say, okay, you're going to have 12 more cycles and then you're going to be menopausal. Can't use it that way. It's more kind of even though it's a numeric score, it's a qualitative reference more than anything. Doesn't correlate with a number. Hey, it's almost 20 minutes to the top of the hour. You're at Fertility with Fink and Friends. I am Fink. You are Friends, and we are live via internet internationally from Colorado Springs. And it sure is nice to see you like every Tuesday afternoon. Simpson 1921 says, I am looking at doing genetic testing, and I heard that it also chooses gender. Does that lessen the chances of a miscarriage? So what you're talking about there, Simpson 1921, is PGTA, pre-implantation genetic testing for aneuploidy. So when we have a tested embryo, it tells us that that's going to be the highest probability of success we can offer with IVF. And that is about a 60% probability of a positive pregnancy test and about a 50% probability of ongoing pregnancy. Now, folks with a normal, or what we call euploid, that word is EUPLOID. Euploid means chromosomally normal. Folks with a chromosomally normal embryo obviously have the greatest chance of success, but unfortunately can still have a miscarriage. So that's why I said it's 60% probability of pregnancy test, but a 50% probability of an ongoing pregnancy. So yes, since most miscarriages occur as a result of a chromosomal or genetic issue, when we take the chromosomal factor out of the equation, and what they're testing is they're testing the portion of the embryo that becomes the placenta. So it's not a perfect system. They're not taking a piece of your baby and doing the biopsy. It's what's coming from the placenta. So it's the outside of the embryo, and that's what's called the trophectoderm. The trophectoderm is the portion that becomes the placenta. So not a perfect system, but yes, it certainly decreases the risk of miscarriage, but doesn't eliminate it entirely. Also, given that since miscarriage is most commonly due to genetic problems, for folks with recurrent pregnancy loss, we usually do recommend IVF with PGT testing because we can eliminate those embryos that are chromosomally abnormal, and that should decrease the risk of miscarriage. What does that cost? CNY has a fee for each of the embryos biopsied, and I don't know exactly what it is. It's not a whole lot, but the lab that we use is called Cooper Genomics, and Cooper Genomics has basically a package that you can purchase. And I believe, and forgive me if I am incorrect here, but I believe it's about $1,500 for up to 8 embryos. I never like to talk about cost of things with people because that is completely outside my department, outside my wheelhouse, but I believe that's what I've been told. So you can do up to 8 embryos for one price, and I believe that's $1,500. Now, some people will do multiple cycles of IVF, and maybe you get 3 blasts from your first cycle, and then you get 4 blasts from the second cycle. Well, by that time, you've got 4 and 3, that's 7 embryos, and so that number 8, you can continue to apply embryos to that over the course of, I believe it's over a year. So hopefully that's helpful there. Good afternoon to all my friends in Miami who have joined. Let's see. What else? More nice words from Amber. Thank you there, Amber. Budaby is asking, what transfer protocol would you recommend for autoimmune patients, specifically Graves' disease? So good question. The immune protocols that we use at CNY are not something that are universal. And in fact, if you go to another IVF practice and say, well, what are your immune protocols? They're probably going to look at you like this. What? This is predominantly a CNY thing because our great fearless leader, Dr. Kiltz, has recognized that inflammation is a big portion of what causes infertility and what causes things like embryo transfers to fail. So we have 4 different immune protocols. The minimum we typically use is immune protocol level 2. Sometimes we will increase that to level 3. So for you, Buddha B specifically, and especially with Graves' disease, I would go with level 3 immune protocol. So that uses some things like Prograf. Prograf is a medication that is an anti-rejection medication. It uses some Plaquenil, which is also an anti-inflammatory that can be sort of interchanged with Prograf. It uses some Neupogen. Neupogen is something that brings up your white blood cell count so that your own immune system can fight off things that are not supposed to be there. It uses Lovenox, a blood thinner. It uses low-dose naltrexone. It uses Intralipid, which is a fat infusion. It's like an IV version of the keto diet, so very strongly anti-inflammatory. And of course, there are a few other things that go along with it. There are similarities between the level 2 and the level 3 protocol. Level 3 adds typically Neupogen and Prograf. Sometimes we do a combination, a level 2 plus, but in your case, I would go with level 3. The other thing I want to mention is HCG boosters. So HCG boosters are basically when we give you that pregnancy hormone and give you a little extra that you inject into yourself after you do your embryo transfer. In the body, those HCG boosters are, it's metabolized as progesterone. So it's trying to increase your progesterone level, which is a good thing because progesterone is what your body needs in order to maintain a pregnancy. Well, in a medicated cycle, we will still use HCG boosters in a medicated cycle. Why? Because it's not going to hurt anything. But do you really need HCG boosters in a medicated cycle? The answer is no, probably not, because we're giving you so much progesterone in the form of vaginal progesterone and progesterone in oil that we really can maintain your progesterone levels very, very well. In a natural cycle, FET, that's where the benefit really exists from those HCG boosters. So if you're planning to do a natural cycle, please make sure that you have those HCG boosters to do, because the evidence is very clear that it does make a difference. So there's my tidbit for the day. All right, let's see. Hi, Andre, my friend. Hopeful in 2023. I had my FET this past Thursday. My midway blood work was today, and both my progesterone and estrogen levels dropped from the day of my transfer. Is that normal? It is not uncommon that happens. Now, if you're doing a medicated cycle, then it is, it has to do with the way that you're metabolizing the estrogen and the progesterone that we gave you. If it's a natural cycle, it's more kind of in the natural thing that your body is doing. But either way, this is something we can address. So yes, I don't want you to worry about that. Those fluctuating levels, the way things change, it does happen very commonly. And that's the reason we do those midway labs. Really, it's the estrogen is less important than the progesterone. The progesterone is really a more important feature. And my friend Andre says, hello from Los Angeles to everyone. Victoria Lynn is asking, can I do another transfer 6 months postpartum after a C-section? My OBGYN says I've healed perfectly, and I would love to have my kids close in age. My two boys are 17 months apart, and just so you know, 3 is the new 2, is what I'm fond of saying. 3 is the new 2. Going from 1 to 2 kids is definitely more than twice the work. And anybody who has 2 kids can tell you that's absolutely true. Going from 1 to 2, more than 100% of the work. But anything between 3 and 10 is just incremental. So you can feel free to keep adding them on, I'm kidding. When can you, having kids that are close in age was a very good thing, because they can play with each other. They are, close to each other in school. I think there are really no real downsides to it, except that it prolongs the amount of time that you are sleep deprived and the amount of time you have diapers in your house. Now, the alternative is you wait some time and then you get a break, but still you go back to being sleep deprived and having to deal with diapers. But you kind of get it all in one big group there. The concern really about having babies close together. You're familiar with the term they used to call it Irish twins. These are Irish twins that you're 3 months later you come in and you're pregnant, and or you and your sibling are 9 months apart. That's what they would always call Irish twins, and we'd all kind of laugh at that. Oh, that's so funny. It's not funny actually, because that's one that really is considered to be the only um, preventable risk factor for severe preterm birth, is that closeness in age, or short interconceptual interval. Now, in reality, I think that if you are conceiving 6 to 9 months after the first baby is born, it's going to be well over a year before the next baby is born. And I believe that there is at least some margin of safety there. So I think if your OBGYN, Victoria, said that it's okay, then it is fine to proceed. From a standpoint of your uterus healing, I wouldn't want you to be having another pregnancy, 9 months later. I'd really be worried about the uterine muscle healing. But by the time you're pregnant and it gets closer to be, at term, I think your uterus will be in very, very good shape. Nothing so much to worry about there. Let's see what else we have here. Doing the HCG wash and the PRP, how many days do you have to stay over? Usually we do that the day, 1 to 2 days before transfer. So I like for people to be here the day before, because it's also optimum at that time that you can do your intralipid infusion. So just plan to be here the day before, and I think we can make all that magic happen. Kayla is asking, what is a mosaic embryo, and is it advised not to transfer? So a mosaic embryo is an embryo. So again, when they do that biopsy, they are biopsying the portion that becomes the placenta. A mosaic is when, instead of having, our chromosomes, we've got 46 chromosomes, or 2 sets of 23 chromosomes. Basically, it's when one set of chromosomes is normal, but the other set is abnormal. That's an easy kind of way to think about it. And that may not be exactly precise, but basically you've got a normal set of chromosomes and some chromosomes that are not normal. Well, the body likely has DNA repair mechanisms. And it's also probable that you can have an abnormality in a placenta that is not in the embryo itself. And so when we have a normal euploid embryo, as we said, that's a 60% probability of pregnancy, which is our highest chance of getting pregnant with IVF. If you have an untested blastocyst, the probability of your pregnancy is about 30%. All right. If you have a mosaic embryo, the probability of pregnancy is about 40%. So it's not quite as good as that euploid embryo, but it's still better than an untested embryo. We know that there's also a slight increase in the risk of miscarriage with that mosaic embryo, but assuming that the pregnancy sticks, you are every bit as likely to have a normal baby as you would be with your euploid embryo. So all day long, I tell people, yes, it is fine to transfer a mosaic embryo. I would consider it to be very unfortunate if you decided that embryo was no good and you didn't want to transfer it, because every day we get cards and pictures and folks bringing their babies in, sometimes even from other clinics where they were told that the mosaic embryo, the other clinic refused to transfer, and they bring in their normal baby to us. So I would feel pretty good about that, Kayla. It looks like Holly is asking, just had my ultrasound. What is a healthy thickness I should have my endometrium for pregnancy? Mine is 22 millimeters, and I believe it's too high, and I have to have further testing soon. So, Holly, it depends on when in the cycle you have that ultrasound done. So, in an embryo transfer cycle, we want that lining to be at a minimum of 7 millimeters. So if you're just kind of doing your diagnostic testing at this point, and it came back at 22 millimeters, the thing I would wonder about is, do you have a polyp? Do you have a fibroid? Do you have something else that's inside the uterine cavity there that may be causing that lining to be unnaturally thick? Now, when we do IVF or when we do an embryo transfer cycle, we always measure that lining in the very beginning at your baseline. And so if we know that at your baseline, you're at 4 millimeters, and then by the time of embryo, by mid-cycle, by ovulation, you're at 22 millimeters, then I would say you just make a lot of tissue there, sister. And there's nothing wrong with that. There's no number that we would see that necessarily would tell me that is too much. You can't do a transfer. There's something wrong with that. But certainly if that's the first time that we're looking at it, I would want to know for sure that there's not a polyp or something else on the inside. Let's see what else we have going on here. We've got about 5 more minutes with Fink and Friends today. This comes from Allie. What should your estradiol level be at midways? Well, I will tell you, CNY has some number that they use for that, and I don't even know what it is because it honestly doesn't matter. We really don't need to check estradiol at all for midways. Why not? Because the thing that the estradiol does is to thicken up that lining, and that's the only thing we need it for. If your lining is thick enough, then your estrogen was adequate. Ongoing, we will treat it, but we only do that. And we have had innumerable conversations about whether we should continue to do this. And the reason that we do is because people see on social media that, oh, you're supposed to have your estrogen level checked. And if they don't, they get upset and they start screaming at our global team. And to be honest, really the important feature of the estradiol is what it's done to your lining, not what the level is in the laboratory. Hopeful in 2023 says, I did an intralipid infusion before my transfer in Colorado, but can't find anyone to do it locally. Is there an alternative I can do maybe even at home? Well, unfortunately, there isn't really an alternative to intralipid. It sort of is what it is. It's not like there's some pill form that you could take instead. Some people actually use veterinary clinics, or many people will have friends who are nurses who are willing to start an IV for them and let that intralipid flow in over the course of 20 minutes. It's very, very safe. That's probably the most common thing that I've seen, either vet clinics, which has got to make you feel pretty, yeah, I always know when I get sick and go to the doctor and I'm next to a bull mastiff and a Great Dane, it makes me feel wonderful. Or have a friend come over and do it. That's often the better choice there. Let's see what we got here. It looks like Ariel is saying my HCG 9 days post-transfer was 44. Then 11 days, it was 140. Is that good? Honestly, yes, honestly, that's fantastic. So we look to see that HCG level double in 48 hours. And so I would have 48 hours later, if it was 88, I would have been satisfied. Yours was 140. So yes, my friend Ariel, you know what that means? That means a gender reveal is, God willing, in your future. I see strollers and car seats for you. So congratulations there. Oh, let's see what we got here. Megan Downey is asking, let's see. I think we already talked about that one. That was how the AMH jumped so much. A couple of folks. Hola, Mayfer from Colombia. Glad to have you with us. When is Sarasota actually opening? Well, you know what? I keep getting asked that question, and I wish I had a better answer. Don't know. It was supposed to be July. It got pushed off to August. Now it's pushed off, probably another month or so. They're waiting for some different permits and some different equipment and things like that. But very, very soon. It's a beautiful office, I'm told, staffed with some really great people, and can't wait to have Sarasota as a part of our full service IVF family. Let's see what we got here. A couple more questions I think we have time for. What is the generic name of Follistim? let's see, I may have lost one of my microphones there, so hopefully you can hear me now. What's the generic name for Follistim? Follistim is a brand name only. So there is Follistim and there is Gonal F. Those are the two FSH drugs that we use. Well, we are winding down here today with just about a minute left. I want to say thanks, of course, to everybody for being with me with Fertility with Fink and Friends from Colorado Springs. We're here every Tuesday at 4 o'clock Mountain Time, 6 o'clock on the East Coast. And I just want to say what a great group of people. Thanks for all your questions. Thanks for your support of each other, because honestly, the world is not such a nice place anymore. So when we see people who are being kind to one another, it really does my heart good. And I hope you too feel the same way. Remember, as I am fond of saying, infertility is not your novel. It ain't your book. It is merely a chapter. And what we're here to do is to help you rewrite that. So until next time, God bless you all. Thanks so much for being here, and I'll see you next week. Good night.